It's not as in the presentation before. I have to say that I was impressed by the clinical condition of the previous case. So, it's a different topic. We'll just discuss about the new boundaries and the new advances in technology, precision, and multidisciplinary teams in cardiac surgery. First was the evolution of access from median sternotomy. We went to right mini thoracotomy. We moved to totally endoscopic and robotic surgery. And of course, there is the transcatheter approach. The robotics integration is a new era. We started with a mitral valve repair, but now it keeps expanding. You have a very good view, 10 or even more multiplied the magnification with tremor suppression, and you can do pretty much everything nowadays robotically. You have a faster recovery. I can show you here the ICU stay, the total hospital stay, and the 30-day readmission rate has gone down dramatically. The expenses are higher, of course, but I think the more we use it, the more good results we will have, and I think that the cost will go down as well. And you can see the patients with different approaches, with sternotomy and minimal invasive is not even robotic. Now we have even for the myocardial revascularization and the endo ACAB, we use the robots because we have this precision, and there is shown that this durable patency for the Lima 12AD graft, which is the most important in cardiac surgery. And it's proof that we have 98% 5 years patency. We should not forget that the 10-year survival mandate has shown that CBG is better from PCI when we have complex coronary artery disease cases. But we know that we still have a lot of PCIs every day in less complex cases, let's put it like this. Of course, we have the evolution with the TEER, the mitral TEER, now it's the Pascal. Previously, we had different devices, and everything keeps expanding every day, having different uses. Now we have this in the guidelines as well, the use of the TEER. For upgraded, the upgraded recommendations say that we can have it class 2A for primary mitral regurgitation, while for secondary MR, we have class 1 recommendation, and it's quite impressive, as well as the tricuspid valve TEER. And it has the important thing is that we have almost 75% improvement, clinical improvement, when we use in severe secondary tricuspid regurgitation combined with the optimal medical therapy. And here are the guidelines of 2025 that are revised, and they include for first time the minimal invasive cardiac surgery for the mitral valve repair predominantly, and the TEER devices. And then we have apologies, it's not great here. We have the intercontinental telesurgery. It's the first intercontinental robotic cardiac procedure. Was done with a 5G, and now we don't have the expertise gap, but we bring all the surgical minds together, and we can do something in real time from a long distance. The evolving paradigm is something that we discuss every day now in cardiac surgery, because from watchful waiting, we go to precision and early intervention. So we reshape the whole standard of cardiac care. We have early TAVR, as we say, even for asymptomatic patients, because it's shown that we have a 40% reduction in heart failure hospitalizations when we are a little bit more proactive, even in asymptomatic patients with severe aortic stenosis, though. The market growth for TAVIs is an increasing market everywhere, I think, and nowadays in Greece as well, and in whole Europe. Another thing that I'm trying to put everything together so we know what is important in cardiac surgery. So the other advancement is the branch devices that we have as an endovascular tool. And the cerebral protection that we can have with the embolic protection during complex arch repairs. And of course, the standardization, having aortic team workflows and having follow-up and discussions about how you treat the patient before. This is the physician-modified endovascular grafts that they have started over the last couple of years to be more used in emergency cases. You can make a fenestration so that you can accommodate the vessels while you are in theater. So you take it in the back sterile table and then you fix it prior to the implantation. This saves us the time that you have to wait to get a fenestrated graft for cases that can wait. But if there's a dissection, you can't. And then we have the artificial intelligence and the imaging that have completely changed the scenery, because we have the CT and the 3D echocardiogram, and we have impressive images. I'm glad that the video is playing. And you can see before and after the case. I think there was one more. Anyway, and you can send, so you can fix the valve, and even if there is a complex situation, you can do it really, really well. And then the AI is our intraoperative co-pilot. So we can predict the hemodynamics. We have a real-time analysis of the vascular resistance. We can have autonomous suturing for the robotic assisted operations. That is path planned for repetitive task automation and during the vascular anastomosis. And of course, the digital twin fusion, which you actually can have a holographic overlay of a patient-specific CT data onto the surgical field for landmark identification. And you can see everything in front of you, and you can say where is what, and you can avoid injuries. As I said, with the digital twin concept, you can have a specific patient modeling. You can simulate before the hemodynamics and see how it's going to respond. And particularly when you have complex structural interventions, this is very, very important. So that's why we love AI. And then we have the new frontiers in heart failure, and we have the ex vivo perfusion. And so we managed to have ischemic times effectively, even DCD donations for the transplantation. Then we have the minimal invasive valves that is much less traumatic for the patient. And then we have the artificial heart with the next generation biocompatible pumps, and we're moving towards long-term permanent solutions. The current research focuses on in situ engineering. So we have patient-derived mesenchymal stem cells, and we're moving from the synthetic valves to living conduits that can grow with the patient. This is important, particularly for pediatric patients. And then we have the pharmacological synergy. Well, just the GLP-1s, we have to say that they have reduced the 20% reduction in MACE. So in patients that have been submitted to coronary artery bypass grafting, there is a significant absolute risk reduction with prior bypass surgery using the semaglutide. And even we have a reduction in LV mass and pericardiac adipose tissue. And the heart team, how can we not mention the heart team? Now, the heart team has evolved from a guideline recommendation to a functional operational unit for complex cases. We have shared decision making, and we don't only have cardiologists, surgeons, we may have geriatricians, nurses, and we take into consideration what our patient wants, what they need. Of course, we have hybrid ORs, operating theaters and workflows, and we have a real-time collaboration in high-tech environments for combined structural and electrical repairs. And last but not least, we have the ERAS protocols in cardiac surgery now. We had implemented this in general surgery, But now the paradigm is shifting from the legacy care models to the ERAS approach, which is standardized, patient-centered bundles designed to minimize the surgical stress response and accelerate the physiological recovery of the patient. Instead of the watchful waiting of the intensive care unit, we move much more forward. We have three foundation pillars. We have the preparation of the patient with nutritional loading and prehabilitation, so we can have physiological repairs before even we go for the bypass, for example, for any cardiac operation. And then during the intervention, the anesthesia, standardization, and goal-directed fluid therapy to maintain organ perfusion. And of course, minimize the pain in mostly the restoration period, as we say. We have an early extubation and aggressive mobility from the first hours. So we prevent secondary pulmonary complications. We manage the medication in such a way so the patient is not in any pain. And having in mind with minimal invasive cases, the pain is much less anyway. And now we have the measurable results showing that the hospital stays can get increased by 2 days, which is quite impressive. And the ventilation hours can go down from 8.4 to 3.8, which is also important to avoid pulmonary complications. We need to remember that we have the multidisciplinary synergy and the heart team, and we need to meet every week and have a discussion between surgeons, anesthetists, and nursing for continuous loop learning. And then we have the shared execution with surgical playbooks, as we can call them, to ensure every team members know the next step before we do it. What about the 2030 horizon? We expect to have remote telerobotics, so we can overcome the geographical barriers for specialized heart care, even in rural environments. We can have AI autonomy with computer vision guided and semi-autonomous robotic maneuvers for suturing or even cannulation. And of course, the cellular repair with bioprinted cardiac tissue scaffolds integrated during standard surgical repair. Let's see how it's going to be in 2030. And of course, we have the intercontinental TER surgery, where the 5G enables the robotic cardiac procedures to be conducted across continents, demonstrate a breakdown of geographic barriers through surgical excellence. The expertise is now a service, but not a location. What we need to remember for cardiothoracic surgery is going a rapid evolution. I guess it depends on how much we spend about this, because it's also a relevant prognostic, if we can say, factor. We have the robotic surgery and the telemedicine. We have the AI with 3D imaging, the endovascular and structural heart innovation, and the physician-modified endovascular grafts, the transcatheter valve expansion with the TR devices, the minimal invasive approaches, the multidisciplinary care, and the shifting paradigms in patient care, including both mitral and aortic valve, make us more proactive, and personalized care and ERAS protocols so we can optimize the recovery of the patient. We need to remember that the surgeon of the future will not be measured by the strength of their hands, by the clarity of their data and the breadth of their humanity. That was the presidential address in the STS Congress in 2026. Any questions, please? Thank you for your attention.
You must be really happy being a cardiothoracic surgeon.
Well, actually,
All those things happening.
it's a lot happening. As I said, it depends on how much money we can spend on getting better in all this. United States still are leading, but I hope that we in Europe we follow pretty quick.
This is the nice touch.
Thank you.
Any other questions? Or you are just amazed?
Well, I try to show that there are many interesting things in cardiac surgery. I don't know if there are any cardiac surgeons or want
We
to
talked
be
earlier
with,
about TE in ORs
yes.
in general and in ORs, but I think that that was it.
Yeah, because there are people saying, "Oh, cardiac surgery, you can't operate much because you have all these devices, steer, TAVI." But actually, if you operate in a minimal invasive way or in a robotic way, as we do for the laparoscopic occasions, for the thoracoscopic occasions, for the lungs, I think we progress and the patients keep having a good care.
Yeah.
Thank you.